Hello there. Welcome to the A2E assessment with me, Dan. Let's crack on. So we have Dr. A, B, C, D, E, F. So you'll notice a couple of things I've added. I've added doctor and I've added F to it. So what wonderful thing could this mean? So D. D is for danger, of course. So we always begin by saying danger. Is there a danger to you, your colleagues, your patient? Are you in danger? If so, get out of there. R, response. Now, response is twofold. Try and get a response from the patient. And if you're not getting a response from the patient, you can't do this alone. No, senior consultant can do this on their own. You need help. So, do you receive a response? If not, get a response. Pull the buzzer, bzz, a nurse will come and help you. A for airway. Okay, so now we're on airway now. So think of A4, and that's why this little bad boy comes in. So we've got a paper aeroplane, an A4 sheet of paper. The 4 S's that you need to know for airway. First of all, speak to the patient. If they're talking back in full sentences, well, you know their level of consciousness. You also have a pretty good idea as to the fact that they're maintaining their own airway. Okay? So speak to them. Have a look in the airway. If the speaking isn't so good or if there's some added sounds, what's going on there? So C, you might need to do some suction, but only suction what you can see and then secure the airway. Now, this is a really important point. So we can use an OPA, we can use an MPA, oropharyngeal airway, nasopharyngeal airway. You'll be taught how to do this in BLS. Hopefully most people watching this video do know how to do this. If they are tolerating an OPA or an MPA, it's likely that you're going to need to inform the on-call anaesthetist that there is a patient who has such a decreased level of consciousness that they are needing an A2E assessment and are tolerating an airway adjunct. They should be spluttering and coughing because, it's a big thing going down your mouth. It's a big thing going up your nose. It should be uncomfortable. If the patient's tolerating it, then this is not a very good sign. Something needs to be done here, okay? And they're probably going to want to be aware of it. So when you put out that call for help, when you put out the MET call or the medical emergency team call, whatever it's called in your trust, you might also want to inform the on-call anaesthetist that this is happening so they're prepped and ready that on ward 6, something could be going on soon, okay? So when we talk, I've just zipped across. When we talk about B and C, when we talk about B and C, we're talking about breathing and circulation. Now, really, we can do these together. Should we do them together? Oh, no, because it's autodepressant for what's going to kill you. But for the fluidity of the assessment of a relatively stable patient you've been called to see at night when you're doing 10 of these in one night shift, you can probably get away with doing B and C together. That said, for the purposes of OSCEs, B first, then C. So, similar to an MSK exam, we're going to do look, listen, feel, move. Cool, right? So let's move B and C across so we can do it in turn. And there's some commonalities here. So look at the observations. Which observations are pertinent for B? Respiratory rate, saturation. Usually there's an OBS machine in the corner telling you. B, breathing. Say to the patient, any problems breathing? Look, are the accessory muscles being used? Are they tripoding? Are they struggling to breathe? Do you hear any added sounds? End of bed inspection here. And then C, the colour. Do they look blue? Are you going to listen to the chest and any lung bases? Any lung bases? The lung bases. You're going to feel cat, okay? So feel the chest expansion, having your thumbs off the chest, having that move. Keep this hand down for the apex beat, and then move it up for the tracheal deviation. At this point, move to do something. If there's a problem in B, stop, throw them on some high flow oxygen, and consider an ABG. Realistically, it's not likely you would stop the A2E assessment and do an ABG, right? But if there's a problem in B, you might consider doing an ABG. A lot of other countries would argue that Britain overuses ABGs. Maybe a VBG and an oxygen sats probe is enough for most things. Whatever. C. Now look how similar this is. So it's not OBS breathing colour, it's OBS, so the rest of the OBS. So you need to see temperature for perfusion. You need to see heart rate. You need to see blood pressure. Bleeding. Is there any overt bleeding that you can see going on? There's a giant red pool around the patient. Oh dear. Hopefully that's something you would have spotted by now. And then colour. Pallor. Are they pale? Listen. What are you going to listen to in C? I wonder. That's right. The heart sounds. That's what you're going to listen to. Feel. Now, what are you going to feel? Now, there's a flow to this that you can do to make sure that you do everything. Start at the hands for feeling. So feel for peripheral capillary refill time. Okay? Then go from the finger to the wrist. Take the radial pulse for rate rhythm. Take a second pulse, either brachially or carotid. Okay? For character volume. Stay on the neck. Look at JVP on the right-hand side. Have the patient turn their head to the left, right-hand side. And then capillary refill, central capillary refill time over the sternum. We're going to move now. We're going to move on to AEIOU. So what is this all about? So that is about access, getting access for the patient. E, ECG. I, IV fluids. O for organism. So now you're thinking, ooh, could this be sepsis? U, urine output. And you can't get good urine output without a catheter. Particularly in an acutely unwell person, they're going to need this. So I've thought, okay, oxygen and ABG is pretty easy to remember, but to remember all of the things for AEIOU, that's why I use the vowels to clump them together. So at 3 o'clock in the morning, if the patient has a problem, you do it. And so what we're saying here, quite simply, is if there is a problem with one of these sections, so say there's a problem with the chest and bases, then oxygen ABG. Problem with capillary refill, then AEIOU, okay? So if there is a deficit in the look, listen, and feel of B, you move to do this. If there is a deficit of look, listen, and feel of C, you move to do this. You do not have to do all of the moves. You do not have to do all of the moves if it's normal. Relatively simple. How does this play out in real life? So I've got a patient and I've got an OBS machine here. So look at the end of bed, okay? So first of all, look at the OBS machine. This is what I'm saying when you can do B and C together, right? So watch what I would do. I walk in to review this patient who's unwell. Doctor for danger. So is there any obvious danger? Response, hi, Bob, can you hear me? Yes, I can hear you. Okay, so instantly, there's no danger. He has responded to me, therefore he is maintaining his own airway. Okay? So we're already, in a few short seconds, hi, Bob, how are you doing? Oh, I'm okay, thanks. My eyes glance to the OBS machine or the OBS chart. Right? So in 5 seconds, we are, oh, there's no danger. He's not, wielding a knife. There's no water on the floor. I'm going to slip over. There's no family member who has a giant axe who's trying to kill me, fine. Response, he's responded to me and he's responded appropriately. Airway, maintaining own airway. And then you look at the OBS machine. 90% of the patients you go and see are going to be like this. They're going to pass this section and there's going to be nuances on these sections, which is why we get to these sections, okay? That's why it's all included. Oh, my word. I've gone on too far. So we've assessed for danger. We've seen if this is a response. We've looked at the airway. Now we've moved on to B and C. So in B and C now, what I'm going to say to you is something rather straightforward. So look, listen, feel, move. Look. I'm looking at the observation chart. That looks okay. All of the metrics are relatively okay. He's snoozing a bit, but he's not about to die on me instantly. So OBS, noted. Breathing. Bob, can you take a big breath in for me? Hold any pain. I'm thinking about pleuritic pain. I'm thinking about chest pain. I'm thinking if there's difficulty in breathing, obviously at the end of the bed. Colour. Is he blue? Is he pale? Bleeding. Any overt bleeding. That's look. Done. Listen. I'm going to go ahead and listen to the chest in all of the regions, anteriorly, posteriorly. I'm going to have a listen to the lung bases. I'm going to have a listen to the heart sounds. Aortic, pulmonary, tricuspid, mitral, any accentuation maneuvers if I'm feeling a little bit extra. So I've done now, look, listen. So feel. So what I'm going to do is to grab the chest like this, big breath in for me, and see if my thumbs lift off equally. I'm going to leave this hand here, right in the 5th intercostal space midclavicular line to feel the apex, to feel if there's a deviation. And with my other hand, I'm going to go to the suprasternal notch and feel for the trachea to see if it's deviated at all, which you can do in the suprasternal notch. You don't need to be palpating all the way up the neck, which is really uncomfortable. Whilst I'm at the neck here, why don't I feel for central capillary refill time, look at the JVP, feel the carotid, and then come down and feel the radial. Because that is then a flow from down here all the way up here. So look what I just did there. So if we are doing, for instance, so for feel, for B, it's chest expansion, apex beat, and tracheal deviation. And then for C, it is capillary refill time, it is JVP, it is carotid, and it is radial. You see how they can flow. So do the chest expansion, keep the hand there and feel the apex beat. With the other hand, feel that, have them turn their head, look at the JVP, okay? Press on for capillary refill time, do the carotid, do the radial. Not so bad, is it? You might want to do bilateral radials as well for radial delay. You really don't want to miss a dissection, do you? So that's DRABC. D is a piece of cake. People are always like, ooh, do I put temperature in this? What do I do? I've forgotten the sugar. Never forget the sugar. You're not going to forget the temperature because you've already looked at all of the observations in B and C. So the temperature you have now assessed. That is noted. So for D, all I want you to think about is ABC. ABC. A for AVPU. B, EMS. What was the last BM? If the AVPU is a bit low, alert, voice, pain, unresponsive, and you can add confusion as well. So a lot of people say ACVPU, alert, confused, responding to voice, responding to pain, unresponsive. This is a surrogate for GCS that's obviously not as good, but is fine at 3 o'clock in the morning. BMs. So if there's an AVPU issue, do BMs. And then C, constrict, dilate, so pupils. And the magic thing that we want to see is do the pupils look equal in size, and are they responsive to light? Pearl. That's what you'll see written. Pupils are equal and responsive or reactive to light. So do the swinging light test. E, 2 E's. Exposure and embolism. Now I know that it can be tricky to ask a frail person to undress at 3 o'clock in the morning when they're knackered, but they're in hospital, they're unwell, they need support, and if you can talk to them and say this is important and have a chaperone, you can't do a general exam without exposing the patient. You can't do a general exam without looking at the patient's skin, and you can't selectively look at the patient's skin because the majority of the surface area is clothed. That's why we have clothes. That's why we have clothes. So, fully undress with a chaperone present. If the nurse has paid you to see a patient, the nurse can be brought in. They're concerned about the patient. Come as my chaperone. Wonderful. The nurse can tell you if this is the patient's baseline. They know the patient even more, right? So if the patient's confused, you can say, Bob sounds a bit confused to me. Is this new? Oh, yes, he's always been like this. Or, oh, he's not confused. Or, yes, this is very new and I'm concerned about him. It's important information, particularly if there's not a family member there. But you always need someone who's an employee at your trust to be a chaperone. Nurses are ideal. Then exposure. Done. So we go to embolism and we're looking for the DVT signs, right? Thromboembolism. So check the calves for asymmetry, rubor or redness, pain or dollar on deep palpation. If it's pain when you touch it lightly, that's more likely a superficial phlebitis, superficial thrombophlebitis, cellulitis, or erysipelas. It's got to push in deep, and because you're getting to the deep veins. It's deep vein thrombosis. So again, deep palpation to feel the pain. But see if there's rubor and asymmetry of the calves. One massive, one not so massive. Then we come to F. This is what I've added, and it's feel. It's feel the tummy. Importantly, med students all the time when I'm doing bedside teaching, they don't do this. Feel the tummy in each quadrant and observe the patient. You need to look at the patient to see if there's any signs of peritonism. You need to see, like going, when you push on a quadrant, it's really important. Okay? So, let's quickly summarize the A2E assessment. D, R, A, B, C, D, E, F. So, D for danger. Is there danger to me? Is there danger to you? Right? R for response. No response, get a response. A for airway. The 4 S's, remember? Speak to them. C, suck, secure. B, breathing. Look, listen, feel, and move. Look at the observations. look at the breathing, look at the colour. Listen to the chest, feel chest expansion, apex beat, tracheal deviation. Move to oxygen therapy, ABG. What about C? C for circulation. So look, OBS, bleeding, any overt bleeding. Colour. What's the colour of the patient? Are they pale? Therefore, are they underperfused? Sign of shock. Are they flushed? Sign of sepsis? Distributive shock? Listen. Listen to the heart sounds and the lung basis of heart failure, particularly acute heart failure, right? Flash pulmonary edema. Feel. Feel the central capillary refill, JVP, carotid, radial. Move, AEIOU, access, ECG, IV fluids, organism screening for sepsis, and the urine output, catheterize them. D, disability, your ABC, AVPU, BMs, constriction and dilation. E, exposure. Undress the patient with a chaperone, check for the calf asymmetry, pain to deep palpation, and ruber. F, feel that tummy and look at the patient. Don't forget to look at the patient. Don't forget to look at the patient. There's your A2E assessment. Thank you very much.